I'm a medical physicist. I'm happy to represent today our medical physics unit from EOC in Bellinzona. So we were talking today a lot about the online adaptative, but maybe we should also say a few words about the offline adaptation. And this is our strategies and opportunities we have in our hospital. So the presentation shouldn't take more than one full treatment fraction with the imaging of the prostate using standard LIDAC. So in EOC, we have two sites of oncology clinics, radiation oncology clinics. So we are in Bellinzona and we are in Lugano, both beautiful cities. I highly recommend if you are still here for a few days to visit them both. So in Bellinzona and also in Lugano, we have the variant TrueBeam LINAC. Also in Bellinzona, we have our imaging CT, our MR, and the deep and superficial hyperthermia unit. The superficial hyperthermia we also have in Lugano, and on top of that, we also treat with the Exopt, Brachy, and IRT. So in general, we treat about 1,000 patients a year. It's actually 980 patients from the last full year. And the majority of our treatments are breast and prostate and pelvis treatments. So this is generally half of the amount of the patients we are treating. On top of that, we treat, of course, the other sides like a brain, head and neck, lungs, and the bones. So just to make it clear, we apply our offline adaptation to all of the sites. So where we are compared to the others. So this is the paper that was published 3 years ago. And it included the questionnaires from 177 institutions across the 40 countries. And it was asking about the pattern of practice. For adaptative and also the real-time radiation therapy. So here you can see the table that shows you different strategies, different options. So you have like an online planning library, online daily replanning, offline protocols, online and offline protocols, and offline ad hoc. So as you can see, the majority of the centers answered that they do the offline ad hoc adaptive radiotherapy to any sites. And also this is what we do. So we can say we are pretty much standard in our solutions comparing to the others. So our workflow, it's quite simple, I think. So we started here with the treatment fraction and the imaging. Then we move, we use this imaging, of course, for positioning the patient, but also the CBCT registration is used to do the offline review by the doctors. If we see a systematic and anatomical changes, we present this case in our morning meetings, which are dedicated also for the things like this, where we show the case and together we discuss the situation. As a physicist, of course, we are involved in dose distribution evaluation, which can give an extra information for the doctors if the patient needs to be rescanned and replanned. And if so, we do the process from the start. So we scan the patient, replan it, we do the QA, and then we treat again. So let's focus on something that is, let's say, more physics. So the dose distribution evaluation. And here I show you the clinical example. So sometimes the choice is very simple, right? So would you replan in the situation like this? You have your original CT scan on the left, and then after 15 fractions, you have the situations on the right. So completely different shape. The patient had a great response. So the tumor actually shrunk twice. So here, of course, the choice is clear. You will replan. But what if the situation is like this? So you have the prostate patient which arrived to have a treatment, and you see there is maybe 1 centimeter less at the belly, then maybe some 2 centimeters less tissue on the sides. Again, it's not symmetrical, so maybe one side is more, one side is less. What do you do in this situation? Luckily, we don't have to guess. So in our hospital, we evaluated by recalculating the new body outline based on the CBCT. So what we do basically is we take the new body outline from the recent CBCT. And here you can see the two green lines, which highlights the difference. So you have the new and the old body structure. And then you can overwrite the difference with the Hounsfield unit. And here, in respect, if this is a weight gain or weight loss, you of course use the different Hounsfield unit number. So this was the weight loss, which means that this difference, which is highlighted now in pink, it's air. So we override it with -1000 Hounsfield unit, and we recalculated this new body outline with our own old original plan, which gave us an information. And this is, again, I say, like, this is the support information that we can give to our doctors about the dose distribution, and we can compare the DVHs with the original plan. This is not maybe exactly and the most precise thing to do in the world, as we've seen in the presentations before. There are much better, more advanced techniques, but this gives you an extra information which normally you will not have. So this could help potentially to decide if the replanning is necessary or not. In this case, for example, the coverage of the volume, which was the prostate treatment, didn't change completely, so no need to rescan. Are there any opportunities for improvement for the offline adaptive radiotherapy? Of course they are, and I divided them into, let's say, two parts. So, or you go the money route and you invest some money, or you go to the hard work route where you invest your time. So, of course, as we've seen before, there is a lot of, I think, information we also had before. There is now a lot of automated softwares that can provide you really quickly comparison, registration, and highlighting this difference. This difference could be probably easily done with using dedicated software. Of course, you can invest to have better software and hardware for the CBCT calculations. And we are talking here not only about the non-rigid algorithms, but generally the full hardwares like the HyperSight, which gives you also the better image resolution, which is important if you want to do this for the, I think, especially abdomen patients. And then we move to the hard work part, which could involve writing and establishing the internal protocols and the predefined action levels. So in just the easy words, you can just say, okay, if we have the situation like this, if we see the change of the volume like this, what we do we replan or not? And this predefined action levels could answer to some simple questions, like what is the limit that we can accept? And we know the coverage, for example, or the dose to the organs will not change significantly. We are looking into this now even more after introducing the rapid plan models. So we use the rapid plan model to plan, for example, our prostate patients, which give us more unified and robust plans, which are more unified. So we can now say the prostate plans are more equal, which can give us the next step to establish those protocols. The second thing is the adaptation with the plan library, which is especially interesting for bladder and cervix cases, where you prepare in advance few plans with the different scenarios, for example, for the bladder volume. So there is a few ways to do it. And the third thing, this one I need to say, I don't know which hospitals are doing this in practice, but in papers you can also find that there could be scheduled surveillance scans at any given point of the treatment. So sometimes you can do it, maybe it's like a routine rescans. So let's say for this type of treatment site, let's say head and neck, this type of cancer, you have the routine rescans after maybe a week, maybe halfway of treatments, but it's like a fixed point. So it's not a question we do it or not, it's scheduled. Now, I would like just to show you some interesting case of the bladder treatment. So this is the patient we treated with the bladder cancer who had the problems to empty the bladder, which resulted in the lack of reproducibility for the first day of treatment. The patient was scheduled for 20 fractions, so the actual treatment was not that short. The problem was that in general, this patient was supposed to be treated in general with the empty bladder, but because of the type of disease, he couldn't feel if his bladder is empty. So he tried, of course, but it arrived with the different results every day. So because of this lack of reproducibility, we noticed in the first 7 days, seven treatments, we decided also to use the CBCT to outline the CTV deviation. In this case, based on the CBCT we have for the first few fractions, we used the different bladder volumes. Of course, the bladder here is the CTV because this is the target volume. And we have now 3 different volumes. So the high, 243, was the original one. Then we have the medium, which was the outline with a little bit less fluid in the bladder, and the low, which was the lowest we noticed during this 7 days, which was 156. We use our original CT to recalculate these new volumes. So it's like creating the library of 3 different plans to choose between for each day. So now we have the plan which is high, medium, and low, with different sizes of the target. And this approach led us to the conclusion that, of course, if we are treating bigger volume than it actually is, we irradiate more the healthy tissues. So why to do that? Let's adapt and let's reduce the dose, for example, for the bowel, which was quite close in this case. So interesting thing was that we used our ultrasound bladder scanner before each treatment fraction after this. So we estimated the volume bladder before even choosing the plan, which gives us an opportunity to reduce one more combine CT, because normally if you want to do that, you will have to scan the patient first to assess the volume, and then choose which plan is the best, and then do the CBCT again for the positioning if the plan is different from what you choose. So we could skip that by using the bladder scanner, which gives us the reading. This reading could help to choose the best plan of the day. And then we proceed with the standard procedure, so CBCT, positioning, and the treatment. So to show you the fractionation, or how many times we use each plan, for example, here you can see it vary a lot. So the high volume plan was used 7 times, the medium one was used only 3 times, and 10 times below we used the one with the smallest volume. As happy owners of MR imaging, we are asking ourselves the questions: what can we do to use it also for the offline adaptation? And one of the solutions, or like one of the ideas we came across, is using the imaging, the MR imaging for our cervix patients, which could potentially lead us to use it to be more adaptive for this type of treatment. So here in this paper, they are comparing the online adaptation with offline adaptation with 3 different regimes. So with one replan, no replans, one replan, and weekly replan. So the conclusion from this paper is that for standard cervix cases, one replan could have the comparable results for the coverage as the online adaptation, because here there was no not that much differences. Let's say that they published that there are not very less, not superior to that. And also because we are the center who has got the MRI only workflow, this could be potential solution for us to have the rescans for the cervix patient as a standard. So maybe we can schedule this and do it as a routine type of treatment to adapt more. The second possibility, and this is something that was already mentioned, so I'll not repeat my previous the previous presenters, is to use the diffusion weighted imaging, for example, for the head and neck cancers, where you can use the biological adaptation and based on the ADC maps and the values, you can predict and also you can choose which patients might benefit from the treatment adaptations. So in the conclusions, of course, yes, adaptive radiotherapy is the only way forward to achieve the better conformity, the coverage, organs at risk. Of course, we all know this. It could help to do all these beautiful things that were mentioned before. So reduce the margins, escalate the dose, and decrease the fractionation. Our ad hoc offline adaptation approach is still the most common strategy across the radiotherapy centers. And of course, we can make improvements. The improvements, I think, could be always done. So we are looking forward to do that. And also, we are following the news about what are the other MR imaging methods that potentially we can use also offline to be even more conformal, even more adaptive for our patients. So thank you very much for your attention. And I think it took me 15 minutes. So the patient now is finished and another one is waiting in the queue. Thank you.
Hello, Klaudia, for sharing your experience. I have a very technical question, and I don't know if it's probably it's interesting only for me. How did you manage to work in area with the clan library? Because it's super difficult to schedule.
To schedule.
Yeah.
We left it blank, so we just filled the